Wow, and now they're coming in thick and fast. Right, in that case, I think I shall kick off. So I'm Hilary Cass. If we put the next slide on, Guy, we can see who the cast list is for this afternoon. Oops, no, not that one, the next one after, I think. That's it. So we've got a great cast list for this afternoon. I'm the one with many titles who doesn't do the work, but the rest of the cast list, who I will introduce as we go along, are the people at the coalface who are doing all the key work in this area. So I'm just going to say a few housekeeping things, and then I'm going to come back to the previous slide. So just if you have any issues technically, or you want to say hello to your friends, do that in the chat. But we're hoping that there'll be lots of questions, and so please put your questions in the Q&A slot, and we'll try and pick up as many of them as possible. We are recording today so that anyone who's not able to attend can see this afterwards. And we will be sending an evaluation afterwards. Just a word about social media. We would ask you not to screenshot, but please feel free to tweet about the event. Try not to quote our speakers out of context, or repeat anything silly that we all say, but do otherwise tweet about the event. So, who is palliative children's? What is palliative children's palliative care, and who is it for? Try and get that sentence out. So, if we just flip back to my previous slide. So, when I first went and listened to a talk about palliative care, which was given by Finn Craig, and I listened to some of the stories about the young people she was looking after, I said, but those are my young people that I look after as a disability consultant. The term that's actually floating around a lot at the moment is children with medical complexity, who really everyone's looking after. General paediatricians, community children's nurses, the gastroenterology team, the renal team. So we all think that these are our children, because we get terribly possessive about children that and families that we're looking after. And I think they're probably all the same children being looked after by specialists with different titles. So what we want to try and unpack in this talk is how we all contribute and what the various roles are of the many people who are involved in looking after a very important cohort of young people and their families, and trying to achieve really excellent services for them. So with that, can I introduce you to Karen Horridge? Karen and I go back many years. I succeeded her as chair of British Academy of Childhood Disability, but in her day job, she's a consultant at South Tyneside and Sunderland NHS Foundation Trust. And Johnny Downie, who is Karen's a disability consultant. Johnny is a paediatric palliative care consultant in Glasgow, and I always complain that they're always ahead of us north of the border on almost anything, ranging from networked care to you name it. So I look jealously across the border, and they also don't have the complexities of our commissioning structures. So I'm going to let Karen first, and then Johnny just say a little bit about their work. So Karen, do you want to kick off?
Thank you, Hilary, for that kind introduction. Hello, everybody, and I hope you're keeping safe and well in these challenging times. Apologies for the headgear, but multiple people doing different tasks in different parts of the building. So my interest in palliative care has always been completely integrated into my approach to the healthcare for disabled children and young people. It goes back to my days as a medical student when I did a public health attachment in Wrexham in North Wales. I was a student in Manchester, and I did my elective at the Christie Hospital in Manchester, and then my first house job was at the Christie as well, where I learned a lot about symptom management and holistic care. I trained before paediatric palliative care was a choice in terms of formal training. So I cobbled together experience, which I hope has stood me in good stead and which I've learned a lot from, which has included community paediatrics, hospital paediatrics, general practice, and I also did a stint of 6 months in adult palliative care and learned a huge amount about symptom control and aspects of management there. So I've been very lucky to be involved in developing the first curriculum for paediatric disability, and Hilary was on the group that worked with me on that. I guess my thoughts about palliative care all the way along have been that it is integral to everything that we all do as paediatricians. So my clinical practice at the moment spans Sunderland and South Tyneside, soon to be more focused just on South Tyneside as I retire and return. And I provide paediatric care for babies, for infants, for children and for young people from 0 to 19 across all physical and intellectual disability spectrum. I'm really lucky that I've got fabulous colleagues in the community children's nursing teams across both Sunderland and South Tyneside who have built up great expertise over the years and are willing to go the extra mile and to try to meet parents and families' wishes for a place of care when end of life is approaching and to support them as best we can. I should say that in the northeast of England, we don't have a specialist paediatric palliative care service as such, although there's an embryonic one now growing, which is great news, based at the Great North Children's Hospital in Newcastle. So that's just a little bit about myself and my journey, and over to Johnny.
Johnny.
Thank you very much. So it's a pleasure to be with you all this afternoon. So as Hilary's already said, I'm Johnny Downie and I'm a consultant in paediatric palliative medicine at the Royal Hospital for Children in Glasgow. Having been appointed in 2009, I completed my specialist paediatric palliative medicine training in Great Ormond Street Children's Hospital. And a bit like Karen and I had a bit of experience before I started my specialist training. So I had done some neurology, I had done quite a bit of paediatric oncology and bone marrow transplant, and also quite a lot of my time within paediatric intensive care and neonatal intensive care. I guess the Royal Hospital for Children in Glasgow is the largest hospital for children in Scotland, and it sits within a health board called Greater Glasgow and Clyde, which is the largest health board in the UK actually. The population is about 1.3 million adults and children, but the Children's Hospital itself has probably got about 260 beds, and it's the national lead for a number of the subspecialties which are centralised in our hospital. So I guess our small team within that hospital, we are a paediatric and supportive palliative care team, and it's a real collaboration in partnership between Greater Glasgow and Clyde, the health board, and also children's hospices across Scotland, who some of you may know as CHATS. And our team comprises of 2 medical consultants. So there's myself, and I have a colleague, Dr. McIntosh, who's a paediatric oncologist with a specialist interest in PPM. We've got 1 Diana children's nurse and 2 clinical nurse specialists. And I guess really just to kind of run down what our offering is to professionals and to families, we are a consultative service, and we offer services really across 3 main streams. So 1 being complex symptom management, the 2nd being supporting kind of advanced care or anticipated care planning and supportive decision making, and then finally end of life care. And similar to Karen, we look after children throughout their life, so from babies right the way through into childhood, adolescence, and through into transition into adult services throughout their illness continuum. We are very much a collaborative service, and we're very integrated within a number of the other subspecialty teams within the hospital. And I would echo what Karen has said. I think actually that collaborative approach to the provision of palliative care is so important, because actually it is everybody's responsibility. We're really fortunate in Scotland that although we've also got informal networks in terms of professionals, but we actually have a new national managed clinical network for end-of-life care for children. And that's led by my colleague, Dr. Chris Kidson, who's an intensivist, and they're doing a huge amount of work to try and standardise our offering to chat families and children at the end of life. So that's a little bit about me. Thank you.
Brilliant. Thank you, both of you. I should point out, by the way, that retirement and caring is an oxymoron. I don't see that happening, really. But anyway, let her pretend, and, you know, pot calling the kettle black and all of that. So let me come to the first question, and we can see who jumps in first. What do you see as the difference between palliative care for children and general best care for disabled or ill children?
So shall I go first?
Yeah, go for it.
Can you hear me okay? To me, the philosophy that underpins paediatric palliative care pervades everything that I do, starting with the word care, hopefully, but building on expert knowledge, but considering those wider needs of the child and family at every step of their journey. So to me, they're like one and the same thing. And of course, I always have my phone of friends, and I work very collaboratively with colleagues in a whole array of subspecialties, and you know, access you know, online fora to share challenging clinical situations. And we also have a regional paediatric palliative care clinical network that's met informally over a number of years, where we discuss challenging cases together and support each other. So in terms of a formal palliative care team, although one of our community children's nurses was appointed through big lottery money and specifically badged as palliative care, all of our community children's nurses have built up expertise, and we work very much together and call for outside expertise wherever that is needed. So the other thing that I think is really important in this approach is considering children's rights. And oftentimes the emergency healthcare plans that I write are there to actually protect the child's right to advanced paediatric life support, the same as any other child, because when they're well, their quality of life is really, really good. And I think that's something that over my career time, I've seen a real change, because many of the very severely disabled children at the beginning of my career would have been poorly nourished, with crumpled bodies, wouldn't have made it to adulthood, are now surviving, because instead of passively monitoring the natural history of a child's condition, I think we are together much better at being proactive in identifying the needs of our patients and addressing them. And also paediatric intensive care has got much better at turning children round and getting them back on their perches. So I believe very strongly that active treatment can be part of this whole approach, and that advocating for children's rights with colleagues who perhaps have less understanding of a very disabled child and what their quality of life really means in practice. So that's a little bit of a ramble. I hope I've addressed the question.
Great, thanks, Karen. So well, let me go over then to Johnny, who may want to add to that, but also perhaps from your point of view, you could say how you identify which children can benefit from a palliative care approach or support from specialist palliative care service, because you could, I mean, given the large numbers and increasing numbers of children in category 4, you could actually take on, you know, all of the disabled children in Scotland, but you don't want to do that because hopefully you've got many versions. Well, I don't know, there's many versions of Karen, but Karen's counterpart in Scotland. So how do you determine where the edges are of your practice, Johnny?
Thanks, Hilary. So I guess if I start off by going back to the first question, which is really just about the differences between kind of generalised care for children who have got neurological impairment or disability and that of palliative care. And I think I really would echo what Karen has said, that to me, palliative care is a philosophy of care. It's not a phase of illness. It's an individualised blending of interdisciplinary holistic care for children and their families who have serious illness or life-shortening illness. And I think it's an approach which hopefully we aim to improve and augment quality of life through striving to prevent and alleviate suffering where that happens by identifying and treating symptoms and supporting a family socially and emotionally. And I agree that I'm not sure that anybody would argue that they are not standards that we should be measured against for all paediatric care. And it's certainly central to how my colleagues work both within complex care and neurodisability. I think you are right though, Hilary, when you talk about the different groups of children. When we talk about children with complex chronic health conditions, we talk about children with medical complexity, that actually I think for me the role of palliative care and where we fit into this is not so much about a diagnostic group or a condition, but it should be tailored services aimed at a child's phase of illness and their needs. So I think that children with severe neurological impairment, for example, are children that will straddle many worlds in healthcare. So disability in terms of their functional impairment, chronic complex care in terms of their health and medical complexity associated with their CNS condition, and also palliative care. And actually within palliative care, that might be hospice-based palliative care, hospital, or community. And I think what we all recognise is that these children really require and deserve coordinated, continuous, comprehensive and accessible care. And that's really a team approach, and that you need collaboration across specialties to be able to facilitate that. And I guess my way of looking at it, my partner works for the opera, and my analogy therefore is unapologetically related to the orchestra. But I think if you look at the orchestra and you think of the individual instruments that play within that, actually the individual skills that people have, it's the culmination of all of those, the bringing together that actually serves us as the audience. And I think that is very true within healthcare too. You asked about the differences though, and I think there maybe are some differences, and I think that really comes down to what Karen was talking about around about goals of care. So I think that actually palliative care do have a role where the goals of care start to change, and actually their focus is maybe more on home-based care or community-based care. Now that's not to say palliative care as in specialist palliative care, that's the philosophy of palliative care that can be provided by a number of different people. Within the orchestra, I'm a one instrument kind of guy, but Karen plays many instruments, and actually she should be rewarded for that.
Thank you for that. So in that case, perhaps talk a little bit about the added value of a palliative care specialist as part of the team, a level 4 consultant. Where do you think that your training differs?
So I think that's a really important question, and I think it's a question that I'm asked quite a lot, and I think it probably reflects variations in access to specialist paediatric palliative care, variations in awareness and understanding of what specialist palliative care teams can offer. And actually, as we often know throughout the UK, it's based on the necessity of the fact that local clinicians have developed expertise and training in of their own rights and are providing very good level of palliative care. So where does the specialist role fit into that? And I think we do have a role in supporting the population of children who are perhaps more unstable, deteriorating or dying, or those in whom there's a high likelihood of deterioration through our role in terms of symptomatic anticipation and advanced care planning. I think we have a role in supporting kind of complex decision making, and I guess particularly navigating some of the very complex ethical issues that we face around intensive care units in terms of withholding or withdrawing life-sustaining therapy and intervention. I think we also have a role of advocacy, both at a regional and national level, that actually for this small specialty that we need to have a really strong, clear and collaborative voice. I think we have a role in supporting and working with our colleagues. So I think this is really, to me, about having a kind of hub and spoke model of empowerment and enablement, so that we are enabling people to continue to fulfill their role and actually support the families. But if they need support and advice from a specialist, that is able to be provided. I think we also have a role in research. We are a somewhat research-light specialty, and I think we have a real role in trying to champion that forward. I think what I would say to you is that within my own practice in Glasgow, what we definitely have seen, that since the specialist palliative care team has been started, that we are now being referred children that would not have traditionally been referred to the palliative care services that are already in place in Scotland. So actually there's a distinction there. And I think we also have seen a real desire from our colleagues for integration of our service within them. So I think there is a uniqueness in sometimes about what we are offering. But again, it all comes back to the variations that we have across the country and trying to work within that.
So the sum is greater than the part, as is the case with your orchestra. So Karen, coming back to you, you said that you work without only an embryonic specialist palliative care service in your patch, but you talked about phoning a friend. So, you know, how do you access that additional specialist support? And then also, I mean, you're an extremely experienced paediatrician who throughout your career has kept up a balance between acute and community-based roles. For the younger generation coming through, where do you think they may have challenges through that lack of the longitudinal experience that you've got, and how can we help them?
So to address the first question about my phone a friend, it depends what the problem is, because if it's a particularly challenging symptom, then I will think about I will target it towards the person who I think is going to be able to A, be available at whatever time of day it is, and B, address that issue. So I think it's different depending on what the situation is really. In terms of empowering my colleagues and junior staff and trainees coming through, I've always strived in my work to not create person-dependent services, but to empower and enable others. Because I want to know that if one of my patients is approaching end of life when I'm on holiday, that my colleagues are going to be able to step in and provide continuity of care so that the family continue to have a positive experience. And how have I achieved that? By embedding myself within the paediatric team and by demonstrating the benefits of a little bit of extra knowledge that I've perhaps gained over the years, and then empowering my colleagues not to be afraid of going out into people's homes and meeting them where they want to be, or managing a dying child on the ward. I've tried to encourage people to be confident with the medicines that we commonly use and to signpost towards resources. So I think for younger new consultants coming through and for trainees, I believe that recognising that death might be a possibility, either sudden and unexpected death or death in the course of an illness, is absolutely everybody's business. And I don't think we're there yet in terms of getting that embedded in practice. And I think we need to encourage trainees to be comfortable about talking about dying and death. And there are lots of online resources and courses that people can access. So, for example, I was involved with the Council for Disabled Children in putting together some resources about emergency healthcare planning and the important conversations that are needed to underpin those. So I think training and teaching, not thinking we know everything, because none of us do, but being willing to collaborate, being willing to reach out to others, but also at the same time being willing to support others and empower and enable them and help them to recognise that what they can do, not what they think that they can't.
Thank you. That's a very positive note to take a pause. And Myra or Guy, have we got some questions and comments from the audience that you want to talk us through and put back to Johnny and Karen?
Yes, yeah. Hello, Myra here. There's been quite a nice chat going on, and one of the things the panelists really loved, Anne Brooks was saying, great definitions, and really like the idea of palliative care being a philosophy of care. And Johnny, there's a direct request. Can you write down your definition? So maybe that's something we can share after the webinar. But Mark Clayton says he's looking for that elevator pitch. If you could describe children's palliative care in just one sentence, what would the words be? And then I've got another question in a minute.
Johnny, do you want to give us an elevator pitch?
Certainly. Not really. Hard question. So I guess for me, I think that palliative care is interdisciplinary care to children and young people with serious or life-threatening illness aimed at alleviating or ameliorating suffering. And by suffering, I mean physical, social, existential suffering. I think that embodies what we do in palliative care.
Thanks, Myra.
Okay, so
yeah, go on.
Yeah, I can see there's a few more coming in, so I'll do this one first. So Emily, who's a place specialist working in haematology in Edinburgh, so not too far from you, Johnny, she says, how do you think play can be incorporated into children's palliative care to help patients, families, and also staff?
Shall I have a crack at that one first? Play, immensely important, because whatever we do as teams, we need to make sure that the life is there for, you know, and to the full across settings. Play is really important across all settings, and it's down to, you know, where the child wants to be, where the family wants to be. But again, it's something that perhaps some people are afraid of approaching in certain settings, but it is so integral to making sure that children can do the things that they want to do and choose to do and participate. And that's where I would agree with Johnny that, you know, palliative care is about identifying each and every need across all dimensions, making sure we're treating the treatable, alleviating pain and discomfort across all domains, and supporting families and listening to families always, whilst always being child-centred and respecting children's rights.
Okay.
Go on.
Thank you. Myra.
So this one is from, I think, I can't quite see all the surname, it's Mohammed Fayoudan. And Mohammed says, what is the difference in palliative care and the care provided by the community paediatric department? And where do you see that demarcation line?
Thank you very much for that question. And I think, you know, it's a question that I think we probably both get a lot. But I think what I would say is I think we need to be less hung up on the absolute boundary line between the two specialties, and actually just recognise that what we're talking about are skill sets. And that actually as a child's illness changes, so as their phase of illness changes, there might be more of a dependency on one service rather than the other, but actually that together we can work with these families. So I don't think they're mutually exclusive. I think there are benefits that community paediatricians or community paediatrics with neurodisability bring, as well as people in palliative care. And I think rather than trying to create these boundary lines, I think really should be tailored towards the child and actually their individual needs. Some of my community colleagues are phenomenal at being able to have conversations with families and support symptomatic management. Others are less comfortable, and therefore my role changes depending on who I'm working with. And I think we need to be flexible to that regard.
What he said, completely agree.
We've got some here in the Q&A bit, Myra, as well, about collaboration with pharmacists. Shall I pick that one up?
Then they're coming on both chat and Q&A. So
well, shall I switch to Q&A for a little while you catch up with chat? So I've got one here. Do you collaborate with pharmacists in your role? I've just joined the palliative care team at the Evelina. They've not yet had a dedicated pharmacist, so it would be useful to know if you have experience of a pharmacist within your team. Johnny, have you got a pharmacist in your team?
So no, I don't have a pharmacist in my team. Although I have.
Don't poach the Evelina one. That's my old home.
Yeah, no, I don't have a pharmacist yet at the moment. Although we have got a bid into management, I guess, to try to incorporate pharmacy services. I think pharmacy services are integral to the provision of palliative care, not only around clinical governance, but I guess in terms of supporting symptomatic management, prescribing, discharge planning. I have had experience of working with a specialist paediatric palliative care pharmacist in my role as a registrar in the Great Ormond Street palliative care team. And I could not sing Bhumik Patel's praises loudly enough. I think having him integrated within the team was a huge benefit. I think one of the other complexities that we often have is that the access to medication in terms of medication availability, but route preparation is also a challenge within children's palliative care. And when I spoke about being research light, a light specialty earlier on, it really does centre around actually medications and the use of medications in terms of symptom management, that we are very light. And so actually having a pharmacist with that pharmacological knowledge is incredibly helpful to aid our clinical practice.
Thanks. So thanks, Rebecca, for that one.
So we have a pharmacist, a children's pharmacist, not a specialist palliative care children's pharmacist, but a children's pharmacist who's incredibly interested in palliative care. And we do electronic prescribing where I work, and we're working on, at the moment, on the adult side. They have some of the common medicines that are used in adult palliative care available as a set, so that there's some governance around dosing and so forth. And we're building a tool at the moment that is going to calculate based on weight and keep things safe with some of the common medicines that we use. So as a pharmacist's daughter, I can't sing the praises of pharmacists enough, and really, really important to collaborate, because we need their expertise to keep us safe and to make sure that we're achieving our goals of symptom management in the best possible way with the least possible side effects.
Right, I can go one better. I'm a pharmacist's daughter and a pharmacist's sister. So, so these are two that kind of go a bit together. This is Rebecca Bedford. I'm a children's complex health nurse who's unpicking palliative care in my workplace. I'm challenging the concept that palliative care is not just hospital and hospice based, and it's a shared responsibility. And then we've got another question here, which is, do you think dignified end-of-life care can be provided in the community? And do you think services are missed if end-of-life care is provided in the community compared to the hospital? So I think those are sort of flip sides of a similar theme. So who wants to jump in on that?
So I think place of care is a personal choice, and it's also a consideration for what the family can manage. What else is going on in the family, what other stresses they've got, and also importantly considering safeguarding issues. You know, our duty of care is primarily to the child, and if we're going to make an offer of care, we need to know that the child's going to be safe, is going to be comfortable, that any change in symptoms are going to be noticed, and that the team is resourced sufficiently to provide the wraparound for the family. So I think it's something that we need to think about really, really carefully, and I think it's something that changes in different circumstances and over time. And I think the priority surely has to be the best possible care in a child-centred way, and trying to embrace the family's wishes where that's possible, but being very mindful of the resources that are available both within the family and within the team around the family to achieve that. We shouldn't be moving towards care at home and then end up with a child who is suffering and hasn't had symptoms addressed.
Anything to add to that, John?
Yeah, I think that's a really excellent question, actually. And I think the majority of the children that we look after in our team die within hospital. And actually, when we think about preferred place of care and death and the conversations that surround that, I think often families make choices based upon what they know to be manageable or that they're able to cope with on the basis that they know what support is available. And I think what we actually really need to be very clear about is that palliative care and end-of-life care are core services, and that there should be statutory funding to be able to support the end-of-life care for children wherever their family choose for their child to have end-of-life care. And I think at the moment that is a postcode lottery, and that it's often dependent on the goodwill of people. And I think we are no longer in a place where we can accept that palliative care should be delivered on solely goodwill. It needs to be funded appropriately, and these are NHS funded services that are then supplemented by third sector services. So I think I'm quite passionate about that.
And then there's another two questions which I think kind of follow each other here. And oops, That's one is, do you think the barriers in understanding paediatric palliative care is the different approach of adult palliative care, which I see as what we would call end-of-life care? That's from Tamara Cow. And then from Children's Health Scotland, I've heard that palliative care in children is different from that of adults, and it's across the whole journey, not just the end of life. So I think two comments that we could take together. And then I want to come to transition after that, just to give you a heads up.
So I think palliative care for children is different to palliative care for adults, because palliative care for adults is traditionally based on looking after people with cancers and then perhaps extending to motor neurone disease and some other neurological conditions, whereas palliative care for children starts with the child and isn't dependent on the child having a particular named condition or even not knowing what the diagnosis is. So I think there are differences. The other difference is there are a lot more adult palliative physicians certainly across the United Kingdom than there are paediatric palliative care consultants. And I think we need to what's most important is having enough people who are competent to identify and address symptoms in a confident way, and to worry less about what they're called. But there is clearly a need for improving research in paediatric palliative care, improving the knowledge base, and then disseminating that and educating the workforce across sectors.
Good. Well, we'll come back to research because somebody's picked up Johnny's comment about that, but I just want to pick up this one first. Oh, it jumped. Where's it gone? In an increasing specialist, subspecialist services, ownership of the young person moving into transition adult medical social care is both a challenge and a disservice to those we care for. How do the panel propose to challenge and influence transition services? That's an excellent question, and particularly with my friend David Strudley in the audience, who spent an enormous amount of time working to improve transition, working with Together for Short Lives, and Together for Short Lives has been doing a number of projects on transition, which Lizzie might want to talk about. But first off, let's see, I know that you're particularly passionate about this as well, Karen. Do you want to come in on that one first?
Yeah, so I'm very fortunate in having some funding from Together for Short Lives as part of the transition programme. And transition is indeed a big passion of mine, because I feel that we need to start early, talk about transition early, and we need to recognise, when I think about, again, over my career, the children and young people who years ago would never have reached middle childhood, let alone late childhood, but they're now surviving to become young adults at the very least, if not middle-aged or older adults. But some, just at the age where transition would usually happen, are at a point where their chests are dreadful, they've got those recurrent chest infections, they're at risk of type 2 respiratory failure. So I believe that transition needs to be a process, it needs to be started early, and it needs to be on the correct pathway. So the work that I'm doing is about identifying which pathways are appropriate for which children based on counting the number of needs that they have. So first of all, identifying those with a learning disability, because we all know that mortality and morbidity for people with a learning disability is massively increased, and the COVID pandemic has highlighted that tremendously. So first base is identify learning disability, get people plugged into primary care health checks. Next base is identifying the group of young people that are going to need ongoing secondary health care that might not be just specialist palliative care, but secondary health care with a designated lead. And I think it's beholden on us each in our own areas to identify who that person is, set up pathways, joint clinics, processes and support. Then the third group are the group where, if you like, the wheels look as though they could drop off at any minute, and they're the most medically frail group of young people. And the pathway that we've developed locally for that group involves reaching from the adult palliative team and massive overlap with myself as the disability paediatrician, with input from the learning disability team where needed and the neuro rehab team where needed. So it's real teamwork, but it takes place as over an extended period of time. And some of our young people have died whilst they're partway along that journey, but hopefully they've got the right people wrapped around so that by the time the family or the young person has reached an age where they need to be plugged into adult services, hopefully the family have built up that confidence, instead of feeling they're dropping off a cliff, that they've got a team that are going to continue to be focused on the needs of the person and have the right constitution of people around them. Now, some of that has involved actually, again, empowering our adult palliative care colleagues to be confident in thinking about the needs of our group of young people. That's a little taster of the work that we are doing on pathways at transition.
Thanks, Karen. I'm going to give Johnny a different one so he can get through as many as possible. And this is particularly directed to you, Johnny. Struck by Johnny's description of this is from Mona, of the specialty as research light, and would be really interested to hear of any specific areas of research that he thinks are most urgently lacking. How long have you got?
Yeah, so I think we don't have long to answer this question, but I think there are a number of areas that need to be looked at. I think what I would say is that clinical staff should be doing research that only clinical staff can do. So we have lots of research in terms of kind of epidemiology. We have very good quality prevalence work from Scotland, from Lorna Fraser. I think where we really are lacking is on the ground in terms of the symptomatic management that we deliver, the drugs that we use. Actually, there is very little evidence around our assessment tools in terms of assessing symptoms, assessing quality of life, and actually also assessing the drugs that we are using. And I think that they're the areas that we really need to move forward on to ensure that we're delivering the very best care for families.
Great, thank you. And do you think there's a role for clinical psychology to be embedded with palliative care services? That's another question.
I think that's an absolute yes. I think we would absolutely love for clinical psychology to be embedded in our service for two reasons. One, because I think it's an essential standard of care to all of the families and the children that we look after. But two, I think we have a huge duty to support the staff that provide this care and input. And I think that's something that we are increasingly recognising that we are somewhat deficient in sometimes, both in recognising and then responding to. And I think actually having that embedded within our these teams in our practice generally as paediatricians and within healthcare is absolutely essential for the ongoing sustainability of the workforce.
I mean, burnout is a huge issue in quite a number of specialties that we work with, and I mean, certainly something we have to guard against. So, David Graham here. Thank you for great discussion so far. In Northern Ireland, we're developing our palliative care network. How can education and training of teams be improved to have solid leaders, e.g. within the training scheme, and also for general paediatric consultants? Those are both issues close to my heart. So that's a massive question. Johnny or Karen, do you want to jump in on that one?
So if I start and then I'll let Karen jump in. So I think education and training is a hugely important part of, I guess, the palliative care team role. And certainly since I've been back in Glasgow, a large part of what I've been doing has been educating and I guess affirming skills that staff already have to be able to continue to be able to provide those. In terms of how we've done that, I think if this pandemic has taught us one thing, it's taught us how accessible we can make teaching to people who don't necessarily need to be resident within a hospital setting or in a community clinic. So actually we've used Project Echo as part of children's hospitals across Scotland, and we have been running a number of different kind of teaching forums. One that I'm actively involved in is a kind of paediatric palliative medicine training forum that's now international. We've got people coming from Hungary, all over the country to be able to contribute to that on the last Thursday of the month. I think it's about trying to, we need to be better at communicating with each other about all of these different regional opportunities. and trying to pull that together to offer people good quality teaching and high level teaching, because I think that is something that we probably all struggle with within our own areas. We are very good at delivering the teaching, but actually filling up our own cups is equally as important. And so actually I think I would really encourage that probably we should be, I think we do advertise through Together for Short Lives, but we need to be better at communicating those things.
Thanks. Karen.
Yeah, I completely agree. And I think it's like anything, isn't it? It's a multi-pronged approach. It's making sure that medical students are taught about palliative care, including for children, that junior doctors, nurses, therapists coming through are confident, and that we have a range of offers of educational resources. Online training, e-learning is all is great because people can do it in their coffee break and pick it up later and fit it in around the busy working day. But I think I certainly seek out opportunities to get in and teach on the junior doctors training programs at all levels of training, teach in-house in our own teaching, and then be involved. So I'm very involved again with Hilary on the development of the Paediatric Disability Distance Learning courses, which are based with Sheffield Children's Hospital and endorsed by the British Academy of Childhood Disability. And they include elements that we'd like to build on aspects of paediatric palliative care and complexity of needs as well. So I think we need to, it'd be good to, I know Together for Short Lives does pull together a lot of educational resources, but I would agree with Johnny that we probably need to be better at communicating what's out there, what's free, that people can easily access, and what's affordable for people from with a range of depths of pocket.
Brilliant, thanks. And then I think we're probably coming towards the end of the time, although we've still got loads of questions we haven't answered, and I'm just wondering if we can perhaps, if there's any possibility, I don't know whether there's any way from the technical guys as to whether we can send answers to people who haven't had their questions answered, but I just want to try and cover off a couple more. This is really about, I think, how this should be embedded in nurse training, and some of our later speakers and indeed our audience might have a view on this and be able to respond as well. My name's Helena, I'm a children's nursing student. Any tips for students who haven't had any experience in palliative care yet? And then there's one from Anna Brooke. I'm a cancer nurse specialist at Birmingham Children's. We used to be involved with the palliative care with the palliative process of our patients, but that responsibility has now transferred over to the general palliative care team, as it's this philosophy of care, and it would be impossible for the palliative team to meet all our patients. Is it something that all cancer patients should be introduced to from diagnosis, as all have life-threatening illness and the potential to need it? So there is that thing about the the interface between the specialist and the palliative care team again. And the tips for our student nurse. Some of the audience may want to jump in and say, Tara's in the audience, and others may want to sort of jump in on tips there.
I think I would be careful as a doctor not to answer the question on nursing training, but I think what really I would say is that it's incredibly encouraging that you are showing an interest in this field. And what I would say is that the needs of, I guess, the experiences of nurses looking after patients at the end of life actually can be very different to the experiences of doctors. How things affect a medical professional compared to how things affect nurses can vary. And I think that stems from the fact that nurses often are at a bedside with a family, bearing witness to all of the experience within a 12-hour period. And I think sometimes we're not very reflective of that and the importance of that. And actually just having that on the ground experience of being with families and bearing witness and spending time with them is so rich and important. I think often we feel that unless we have something we can change something, we have nothing to offer. I think, one family taught me very eloquently once that you didn't need to do anything. It was just being there, bearing witness to what we were going through. And I think that's really powerful. So if I can encourage you as a student to actually just seek out opportunities that you have in the placements that you are currently in. Do you know what I mean? You don't necessarily need a palliative care specific patient placement to be able to get that experience.
Good. Well, Myra and Guy, do you know if there's a way for us to pick up some of the unanswered questions offline or not?
Yeah, we're just making a note of them, Hilary. So, and then we'll chat to Karen and Johnny afterwards about how we can do that.
Okay, and maybe some of our other speakers might want to chip in on some of the answers to the questions, and we could perhaps put out a little document with answers to those questions. I have to tell you that as I was watching the screen, it was a bit like your referrals. As fast as you were answering one, 3 more came along. So we could have had you here all evening, but thanks for being such an interactive audience. But a huge thank you to Karen and Johnny for dealing with such a range of questions so well. Thank you so much, both of you. Good. So at this point, we are moving on to Lisa Pullen, who is the service manager and specialist children's community nurse. And, you know, I don't know whether you're going to pick up on any of the nursing questions we've been having in the course of your talk. We're very jealous because Lisa's down in Torbay in South Devon, which I think is rather nicer than being in London in a lockdown. But hey, over to you, Lisa.
Hi, good afternoon, everybody. I'm just going to share my screen because I've got a presentation, so bear with me while I share my screen. Hopefully you'll be able to see it. Start my slideshow. So if someone could just give me a nod to say they can see that. Anybody?
Yeah, good.
Yeah. Brilliant. Thank you. Right, I'll kick off then. Yeah, thank you for that introduction. I'm a service manager for a specialist community children's nursing team down in Devon, as Hilary says, for Children and Family Health Devon. I've been asked to speak to you about the role of a children's nurse really in palliative care. I've got 20 years experience as a children's community nurse. I've also got a specialist practice degree as a children's community nurse and a master's in palliative care. For the last 10 years, I've been supporting and managing a children's palliative care team. But our service is, I'm hopefully in my presentation going to echo a lot of what Johnny and Karen have said. Our service is I consider to be a children's community nursing service, but we do have 4 distinct teams or specialisms within that service. The 4 teams you can see here, so community children's nursing, children's palliative care nursing, special school nursing and continuing healthcare nursing. So I'm going to talk to you a little bit about the CCN role and what I kind of consider that to be. So the Queen's Nursing Institute have given this kind of definition of the CCN role as being highly complex and skilled with negotiating, coaching, teaching, supporting children, young people and their carers, whilst effectively collaborating with a range of other agencies and services to enable the child, young person to remain in the community. And that could be a definition for a number of other professionals as well. But there are some key functions that they also mention as part of the CCN role, those that you can see in this slide. And I think those are very much key to providing good palliative care, but good care to children generally in the community. And CCNs are often described as core palliative care provision and also the bedrock of good palliative care services. And I consider that CCN skills and functions are fundamental to developing more specialist palliative care skills and knowledge, echoing what Johnny and Karen have both said around actually this is a philosophy of care and it's about developing specific skills on top of core skills. So in terms of models of community nursing, these are varied. There's no national agreed offer for community children's nursing, unlike public health nursing and adult community nursing. So provision is variable across the UK, with some areas of the country having minimal access to a CCN service and some provided by charitable organisations such as Well Child or Well Dar, for example. And there's no one size fits all. What we often find is that services have developed in response to local need or to specific pots of funding. There are the Q&I framework, again, with the Department of Health, does look at 4 categories of community care for children's community nursing, described in the framework. And you can see those 4 categories here, with the aim of supporting children closer to the home. And obviously, children with life-limiting, life-threatening illness, and also those requiring palliative and end-of-life care, forms one of those categories of care. And we know that some children in the other categories will also have a need for palliative care at some point throughout their journey. So palliative care is also core to what CCNs do. And I like the way that Hilary described, actually we're talking about the same group of children really, we just have specialist titles, different specialist titles. So what is palliative care? I probably don't need to kind of, I'm speaking to a palliative care audience, so I don't need to kind of tell you really what palliative care is, but I echo kind of Johnny and Karen's point that it is everybody's business. Children's palliative care is a broad and dynamic and varied, and it's a journey. The journey can be unpredictable and varied, and care needs will fluctuate and change over time, as been described already. And it will therefore involve many, many different practitioners. So it's everybody's business. Any practitioner who works with sick children will, by default, be providing aspects of palliative care. And it is related to that phase of illness. So if we look at the Together for Short Lives care pathway and consider the 6 standards for principles of care, the CCN has a role in every stage of this journey, as do many other professionals. But the CCN can provide that core service, but also some of the specialist skills as well needed. And it is about the philosophy of palliative care is to promote the best possible quality of life and care, to promote choice of place of care, and to support decision making and planning. So the CCN can support at each of these levels in terms of supporting a family with a diagnosis, particularly one that they've known for some time, supporting that transition between places of care and transfer, and being part of that multidisciplinary assessment, developing care plans, both family plans and also end-of-life plan, and also supporting bereavement. And again, echoing what's already been said about principles, I consider one of the most crucial aspects of providing palliative care is the relationship built up between the nurse and the child and the family. And that's often, in my experience, has been key in providing a really good quality of care. And how we build that relationship. And often the CCN can be well known to the family and can be the most consistent healthcare professional, and they've developed a relationship of trust over time. And when the child's condition changes, or particularly in end of life, the family often want trusted professionals around them. They want support of somebody that they're familiar with, as opposed to kind of new professionals or specialists coming in. They also want that consistency to remain. In our service particularly, we encourage early referrals so that we can start to build those supportive relationships, even when there isn't a nursing need. And we highlight the importance of relationships really, and we try to establish those lead nurse roles. And we try to avoid changing nurses if we can. And we will maintain a CCN as the lead nurse, but with support perhaps with one of our palliative care nurses to support that in the ongoing role. The CCN or palliative care nurse often acts as a key worker, coordinating communication, care and delivery of services across multi-professionals and providers. And I think this is another really key aspect of the CCN role. This is just an example of the number of people involved in a child death review for a case that we were involved with a baby with SMA who died, and we were providing end-of-life care. And you can see the number of professionals involved. They're just attending the child death review meeting. So that wasn't all the professionals that baby had encountered in only the 5 months of their life. And it's not uncommon for children that we deal with that are on a palliative journey to actually deal with this many professionals or this many people involved in their care. And that takes coordination. And the CCN or palliative care nurses often acts as that key worker, or lead professional role in coordinating the involvement across all of those professionals. And coordination is vital in effective delivery of palliative care. So the key working aspect is about personalised support and coordination of care for that child and young family. It's about coordinating the care for that child, communicating through one person, keeping everybody up to date. Hugely important when you've got end of life and you're managing an out of hours situation, for example. Liaising with others and bringing other services and professionals in as required. Then there's that emotional and practical support. Again, becoming that trusted relationship with the whole family, supporting them, developing their resilience, listening and providing the support and reassurance that they may need. Then providing information and advice, so empowering them through, whether that's the child and family or other professionals that you're working with, through information, resources and signposting. And then there's the planning and assessment aspect, in being involved in care plans, end of life plans, parallel planning, contingency planning, very importantly, and thinking about place of care. This was just a couple of examples of feedback from that case I mentioned, in terms of highlights the importance there of the key working aspect to and how that can be delivered by the CCN. So if we look at national guidance, the ambitions for palliative care tell us that we need to think about equal access regardless of postcode, and care needs to be coordinated, and that all staff are prepared to care. And the nice guidance for end-of-life care for children, infants and young people talks about children's nursing care at any time, day or night, for children with life-limiting conditions, especially approaching end-of-life care at home. And we know we're not there yet. There is limited access to nursing care 24/7, but we know it's crucial to be able to provide care in the home as a real choice for a place of care for end-of-life. So in order to deliver against these outcomes, we need to skill up the children's workforce, whether that's nursing or medical or any professionals I've said, and has been echoed by Karen and Johnny. The workforce that has the contact with the child and family, they're in a position to care, and it's those people we need to be kind of skilling up, really. CCNs, paediatricians, GPs, those core services, because that's what the family want. They want people around them that they know. So what are the challenges? We know there's a gap, a capacity issue. We know there's a shortfall of CCNs in the UK, with recent reports and reviews highlighting those gaps really, in the shortfall in palliative care provision. We know that only 9 higher education institutes are offering the CCN specialist qualification, none in Scotland. It wasn't in 2018 anyway, and they're very small cohorts, so you're talking numbers of 6 at a time. So we're not training CCNs with that specialist knowledge either. And we know that out of hours provision is tricky. It's not consistent across the country. It's often not commissioned. And in many areas, it's still left to goodwill, which is not right. Doesn't echo the adult services at all. And we know that gaining the right skills and knowledge is difficult when we see very infrequent cases of children, particularly in the community, but palliative care numbers generally in terms of paediatrics. It's difficult to gain that experience, and many professionals only come across occasional cases of children who die in their care. So how do they gain that expertise and experience? And we have, in many areas, limited access to specialist advice and specialist support when needed. There are very few specialist consultants like Johnny across the country, so it's not equal access wherever you are. And CCNs and other generic children's workforce often lack confidence in delivering palliative care and feel anxious, as Karen's already mentioned. And particularly when we're delivering out of hours support and end of life care in the home, that can be very nerve-wracking. So what are the future developments? Well, we need to be realistic, don't we, about resources and funding available in these times of austerity. We can, however, as Johnny's already said, focus on building on what already exists. Yes, we need more funding. Yes, we need more CCNs. We need more doctors. We need more funding generally in palliative care. But in the meantime, there are things that we can do to enhance what we've already got, and thinking about the right person with the right skills, the right time, the right place to deliver good palliative care. So we can think about developing specialist roles, and certainly that's something we've done in our service, is actually that those CCN broad general roles we've enhanced. We've got CCNs with an interest in palliative care, and we've developed those skills. They gain expertise by working alongside other skilled people, and develop experience and confidence. We can think about advanced nurse-led practice. So thinking about advanced nurse consultant roles, symptom management plans written by a nurse and nurse-led, and prescribing, obviously, for AHPs and nurses. But as Karen and Johnny have already mentioned, we also need to think about specialist training and development of staff. So we know there's limited access to specialist palliative care training, particularly for nurses, particularly for children's nurses. But that is something that we can develop and we can work on, and we can, as Johnny said, open our opportunities a little bit wider than just our kind of narrow locality, particularly now with the increase in the virtual platforms that we're now seeing. And I think managed clinical networks have a really important role to play in this strategy, in terms of having regional strategies to reduce those health inequalities, and to think about palliative care over a bigger geography, and to pool some of those resources and actually start setting some of those standards that we've all got to work against. And then also, I'm glad that this echoes kind of what's been said already. For me, it's about that collaborative working across partners, across multidisciplines, and across both specialist and generic workforces as well. So working with our partners, the hospice, the hospital, the community, specialist palliative care teams, sharing our skills, sharing our workforce, upskilling each other, developing each other, and actually working collaboratively. So children's palliative care I think now has greater acknowledgement than ever before, and we can all do our bit to kind of build this and continue to strive forward. And I'll just leave you with that to say thank you. Keep smiling. This is one of our CCNs who adapted her PPE mask for a child who had a hearing impairment and struggled with the mask. So I will leave you with that.
Thanks so much, Lisa. And you'll be glad to hear that, I mean, while you've been talking, I think what's coming through on some of the chats is that people want to learn more. There's CCN asking about how they can access additional training. I think both from the medics and the nursing point of view, people are asking about how they can gain access to specialist palliative care training from whatever their role, even if they're not going down a specialist track. So just to bear that in mind, because we'll have a Q&A at the end, and so I think answers about how people can enhance their skills from student right through would be really helpful.
Yeah.
So finally, can I introduce Jane Gates, who's Chief Executive, and Candida Hazard, who is Sebastian's Action Trust trustee and also retired oncology lead. And they're going to do a double act for our last session, and then we'll
Thank you very much. And I think we're going to be joined by our screen being split, if that's okay. For the presentation. Thank you. Before we start actually, if we can go back to the first slide, if that's okay. Thank you very much. Before we start, Candida and I are going to introduce ourselves just to give you some context as to why we're here today.
So as you know, I'm Candida Hazard. I've recently retired. I retired at the end of September. I was a community children's nurse for quite a while, and then I became a clinical nurse specialist, a paediatric oncology clinical nurse specialist. And I worked in Slough and covered East Berks and South Bucks. I worked with a great team, two consultant paediatric consultants, psychologists, physios, pharmacists, and a great community nursing team. From a palliative care perspective, we provided 24-hour on-call for children that required it. We have a different disability and complex needs team, so it was just an acute team really. We were able to provide 24 hours on call to nurses, so that on a rota, so that families did know who was on call, their numbers, they were able to call directly into us, and that worked really well. So we provided, generally it was for about between 10 days and 8 weeks. With a small community team of 9 nurses, which was the equivalent of 4.5 full-time equivalents, it was challenging at times, but what was great was that we had the support of Helen House, the Children's Hospice, and also from Alexander Devine's Children's Hospice Service as well. And we knew we were on call. We knew that we had support from another nurse. So it was all acute, come from the acute budget. So that was great that we had that support.
Thanks, Candida. And Candida is here today in 2 guises. One, obviously, to talk about her previous role, but also to represent the trust as a trustee. But the origins of our association are that my son Sebastian was actually a patient of Candida's, and she was our community nurse for the last 2 years of my son's life. So today, it's a privilege, obviously, to be here and to give you a slightly different perspective, a non-medicalised, non-clinical perspective on what we at Sebastian's Action Trust believe children's palliative care is and who it is for. So if we could have the next slide, please. So, as this slide says, from one little boy's great wish, great things have come. This photo shows my son, Sebastian, and our charity was formed back following my son's death in 2003. And it was formed very much, it stemmed from his direct observations and the lived experience of a child receiving palliative care. And I think today we talked a huge amount about listening, we talked about collaboration, and we've talked about being user-led. But I think it's really important that on occasions we can very much look at and listen to those who really have that lived experience. 2.5 years of treatment for cancer. Sebastian recognised during that time that there was a huge unmet need from his perspective for places where he could go with his family for time away from hospital, away from home, which is a challenging place, a very busy place, because everybody was so interested in supporting him and finding out about his condition and wanting somewhere where he could go with family, with loved ones, that was private, accessible and exclusive, where there could be memory making and fun with his family and loved ones. Could have the next slide, please. So at Sebastian's Action Trust, we very much believe, we live with the mantra that we walk alongside families from a child's diagnosis throughout treatment and beyond. And this definition is one that embodies the work that we do. We very much believe that our role is to provide social palliative care, the essential support that a family needs but may not recognise, alongside the medical care to face each day as it comes. Now, this definition wasn't actually coined by ourselves. It was coined by another eminently worthy organisation, that is Rainbow Trust, and we're the only 2 organisations to my knowledge, within the UK that practice and extol these virtues. I'm delighted to see that part of the attendees, the participants today, are representatives from Reuben's Retreat, which is the charity that we support and mentor. And I'm delighted to say that they are looking very much to develop their model in accordance with this aspect of social palliative care. We could have the next slide, please. So to us, what does palliative care look like? Well, it's very much scaffolded around the medical, physical and emotional needs of the child. We very much practice a holistic model that is family focused but child centred. Everything that we do starts and ends with the child, but we recognise that if we're to support that child, we absolutely need to ensure that there is the right support mechanisms and structures and measures around the entire family. And that family may differ in size and what it may look like, identity, to each family. For some, that is a nuclear family. For others, it very much involves extended family. For others, it may be that family, blood relatives are not nearby, but actually the friendship network may be incredibly strong. And for others, it may be that they feel incredibly isolated from what they consider to be the old normal from the time that their child is diagnosed. And therefore, it's important to create a new opportunity to have support and engagement with those that do understand, and therefore those that live with similar experiences. We believe that great social palliative care is shaped by enabling families to articulate their own emotional, practical and social needs, and in turn with us being responsive to that. And so our model is very, very much based on enabling families to feel that they can be very much part of how we provide the support. We don't have a one-size-fits-all model. We have a model that extols many different aspects of support and service that families can access, and that support can ebb and flow as is needed by the family at any time. If we could go to the next slide, please. So this is a very busy slide, but it gives you our model of care, and it kind of shows you that we very much start with initial referrals, which may come through a range of different places. That could come through the family themselves, it could come through friends, it could come through a member of the child's medical team. And once a family has been recognised as meeting the criteria, meeting the threshold for us to be able to support, we would be able to then look at that family, meet with that family and scaffold support around them, ensuring that the family members are very much part and parcel of determining what support measures we offer to them at any point. I think an important part of this model, and it reflects what was said by the previous speaker, was the death of a child should never be the end. And obviously, along the lines of children's community nurses still being very involved in supporting families with bereavement, we see that bereavement actually starts well before a child dies. And for us, we are very much involved in providing pre-bereavement as an important aspect of ensuring that people, specialists, support workers are not introduced to families at times when they're at the greatest sense of crisis. We try to ensure that there is that familiarity with the support personnel that we're able to provide before it is absolutely vital for their services to be required. If we could go to the next slide, please. I'm very conscious that time is running short. So what does our model of care look like? Well, as I said earlier, it is multifaceted. It started with my son's wish to create somewhere where families could access respite breaks in a non-medicalised environment. And it's important to illustrate that we are slightly different from a hospice in that we don't provide that on-site medical care. We do very much work alongside hospices, a great number of hospices, and there is that great shared care ethos with the work that we do. But our respite breaks are very much tailoring to the needs of family to have time away from a medical establishment. Now, you may think that then puts families into just a certain aspect of where palliative care may be appropriate. We had a child that died last Thursday, and they were actually staying for a respite break at the Bluebells, one of our centres, 4 weeks before. So it is still very much something that we can work with clinicians and with the right support network around the family to ensure that families can have those breaks right up to obviously very close to when the child may die. So being able to access places like the Bluebells, one of our 2 respite centres, is really important, not just for respite breaks, but also for days out, for times when families can come and have that privacy, that exclusivity, and that ability to access facilities that are totally accessible for them. It also means that it gives them a chance to meet with others and for us to facilitate peer support, which we believe is a really important part, not just of families receiving support, but them also being able to give support to others. And many families tell us that they feel it's very, very important that they're able to support others and not to feel that they're just taking from any organisation. We could go to the next slide, please. Sorry, I meant to say from the last slide, a quote from a family. And it says, "They're different from the medical side. They're more the social mental side. I would say they are just as valuable as any doctor or diagnosis that somebody can give, because everybody needs that, the social side." So, sorry, going to the next slide. So one of the many other aspects of support that we can offer to families through our model is outreach. Now, I mentioned earlier that we are family focused and child centred. I do have to also offer the caveat that we are geographically restricted. The full complement of services that we can offer is restricted to 5 counties, the counties of Berkshire, Buckinghamshire, Hampshire, Surrey and Oxfordshire. Respite breaks, however, are available to families right across the UK, and indeed we support families who come to the Bluebells from England, Scotland and Wales at this time. Outreach support is incredibly important, and this really did develop once we'd opened our first centre, because we recognised that many families said that they hugely benefited from having opportunities to escape from the normality of life with a child with very complex health needs. But what they wanted was that continuity of care. So we developed a model of outreach support, and our outreach workers are very much single main points of contact for our families. And that support, again, is not in a regimented fashion. It is very much tailored to what the families need. It can be as practical as the family needs. It can be about emotional support. It's very much about listening and ensuring that families are able to express their views. On occasions, it's about supporting with advocacy where families struggle to ensure that their voice is heard. Sometimes parents tell us that they find it very difficult to be in a situation where they're surrounded by so many clinicians or professionals, medical professionals, and they feel that they can't articulate their views. So our outreach workers are often very, very good at supporting families, either by just being a presence alongside them or helping them to formulate the points that they wish to make, so that when they have those crucial meetings, they're able to get across the points that they wish to make. It's important to reference also that outreach support is something that is available to our families at home, in the community, or at accessible sites. Sometimes this is within a school environment, sometimes this is within medical environments, whether it's directly within a hospital. It's important to show that outreach support can be responsive and adaptive to the needs of each family. Thank you. And do I have something for that slide? I do. Just to say a quote from the family: "There's never been anything that they haven't helped us with. They've come round and helped us to pack up the house when we were moving. They really do walk alongside you and get through life with you. Sometimes I go out with my outreach worker to walk the dog and talk, or she'll help me with the washing up, just normal life, because they understand that life is hard." Thank you. If we could move to the next slide. Another very important aspect of our offer is child support, and it was great to hear, obviously, from one of the chat questions, the Q&A questions, asking about the importance of play and the use of play therapy. Well, we absolutely endorse what was said earlier. Child support is an absolutely integral part of our service. It is something that we feel is absolutely vital, not just to what we call the supported child, the child with extremely complex health needs, but also to their siblings who may also be really struggling to understand the situation. And again, this goes back to our model of being child-centred but family-focused. We recognise that it's important to scaffold that support around the whole family and not just see the absolute needs of the child, because that child lives within a family, and that family need to be able to be part of the entire journey of that child's life. So child support is incredibly important. We find that we commonly see children who are worried, they're angry, they're confused, some may have very low self-esteem, and some are facing challenges that are significantly beyond their years, unable to articulate how they feel, unable to talk to their parents about it, unable to express those feelings to siblings. There may be issues within families to do with sibling rivalry or guilt or confusion about where a child may stand within the hierarchy of the family network. And we feel it's really, really important to create these opportunities for talking and for playing. Thank you. If we could move to the next slide. Finance and welfare is another increasingly important part, and has been particularly important through this year, obviously, with the effects of the pandemic. Looking at finance and welfare, looking at the impact on families where their financial state and their welfare state has been affected. It is a role that's in part been provided historically by social workers, but we have created a role that's very much focused on providing this specialist field of knowledge, because we recognise from many dealings with the beneficiaries that we support that it's a key part of the work that we need to provide to ensure that finance is intrinsically linked with mental well-being. So time for emotional support is always factored into sessional support when it comes to finance and welfare. A direct quote from a beneficiary said, "Without this support, I don't think I would be able to cope. I wouldn't know where to go. I think I would have just crumbled, sat in a corner and hoped that somebody would help me. You might think you could rely on your own mum, but she's an emotional wreck at these times, as much as everyone else in my family. So just to have someone that wasn't connected, that could advise, guide, and take some of the pressures away was invaluable." We could move to the next slide, please. I'm very conscious that we're running out of time. Bereavement. We obviously talked about bereavement, and very much cyclical within the work that we do. It's an incredibly important part. It starts very much at the point, as the slide says, at the point of the palliative diagnosis. Again, it is never prescriptive. It is always tailored to the needs of the families. It is offered to family groups as a group dynamic, but also on a one-to-one basis, recognising that people grieve in different ways, and grief starts at different ways, and anticipatory grief is something that is unique to every individual. A direct quote from a beneficiary said, "I think it is amazing that as the main person to support bereaved families, she comes and walks alongside you before the bereavement happens, so that you know her before it happens. This is just outstanding." If we can move to the next slide, please. For us, what we're trying to achieve, the impact that we're trying to achieve, is that we want to reduce the isolation felt by our families. We want to ensure that we provide appropriate support measures that continue to ebb and flow as families need them. We want them to feel that they can cope with whatever lies ahead. We want to help to improve their economic well-being, and we are absolutely committed to providing a very safe, an important safety net support that is there, responsive and adaptively for our families. We also want to help to improve the relationships between family members, because we recognise that living with a child's complex health needs and facing the end of life for a child is incredibly emotional, challenging on every level, and families are often fractured at these times. If we could move to the next slide. Referral criteria, again, we support children who are...
Jane, we probably need to wrap up fairly quickly, Jane, if that's all right.
Yeah, just to say groups 1 to 4, very happy to share this slide. The last one talks about reach. I've already discussed that, so you don't need to go through that. The 2 centres mentioned, the Woodlands and the Bluebells, are our 2 respite facilities. It kind of shows where obviously our concentrated support is in the 5 counties that I mentioned, but respite care is available right across the UK. And finally, referrals, as I mentioned earlier, easy to refer to us if you feel that you would like to do so. The referral link is there. Thank you.
Wonderful, thank you so much. Really important to get that holistic overview, because too often we focus very heavily on the medical and nursing aspects and don't walk the talk on the fact that children's palliative care is a completely holistic process. So we're to the wall on time, so I think I might ask if we can write up some guidance from our speakers on ways in which people can access training and support career-wise. But Myra and Guy, are there any key questions that that you think we can pick up in the last 2 minutes, particularly in relation to the last 2 presentations from?
Yeah, sorry, Hilary. There's been quite a few questions about training and education, but I think, Hilary, we can probably pick that up in the follow-up.
Yeah, it'd be nice if we can generate a couple of fact sheets.
Yes, yeah, absolutely. We'll do that right away. So there's one very quick one. Where does Sebastian Trust work nationally and into Wales? And then one on short breaks. Should short breaks be just for children with an oncology diagnosis?
From our perspective, no. Respite breaks are certainly available to families who live in Wales, and in fact, our bereavement care even extends into Wales as well. So yes, we would be able to support applications for respite breaks, and we are not constrained by oncology diagnoses. No, we support children who fit one of the 4 criteria as defined through the NICE guidelines for life-shortening conditions.
Lovely, thank you. And there's just to say, there's a note from Suzanne at Chas saying that their forthcoming manifesto is going big on CCN training and education. There were quite a few questions coming through about that, so just to share that. But I think that's the key stuff. We'll take Hilary and speakers all the questions and look at those that we didn't get to answer and follow up with everyone that's attended today.
So can I say a huge thank you to Jane and Candida and to Lisa for those last 2 sessions. I'm sorry we didn't have more time for questions, but we could probably be here all evening. But fantastic audience, fantastic panel, and look forward to seeing you next time. Thank you very much.
Thank you.
Thank you very much. It's been a pleasure.